Hey everybody, it's Dr. Wood, and today we're talking about Chapter 18, covering our chemotherapeutic agents. So what is cancer? Basically, cancer is this unchecked sort of growth of different types of cells in the body, to where normally we have a lot of mechanisms in place to prevent these cells from growing sort of without regulation. And so these cells tend to break that either through mutations or some other purpose there. And so against a new or unusual growth of tissues, and as you'll see, it could either be benign, meaning it's kind of well encapsulated, doesn't really do anything, doesn't go anywhere, or potentially can be malignant or cancerous. Essentially, if it breaks open or is able to spread, it can either get into the blood supply, it can get into the lymph tissue, it can spread around, and that's where we start to talk about things like metastases that can actually develop there. Now, certainly, different types of cancer can occur all over the body and different types of tissue here, so I'm not going to go over each type. I'll tell you the one that I deal with most frequently, being in the pediatric sort of realm, are going to be blood-forming tissues. So for instance, a lot of leukemias are very common in childhood. For whatever reason, they tend to be more susceptible to it than, say, adult patients. And so we spend a lot of time treating those leukemias, hopefully causing these patients to go into remission, meaning we've gotten rid of all the cancerous cells and keeping them there. Otherwise, the cancer may come back potentially. And so some of the things that patients should be worried about if they see these pop up, and it's kind of a mnemonic to help think about some of possible reasons to come get checked out, because it could be cancerous. A lot of times it won't be, sometimes it might be, right? And of course, anytime a patient has a symptom that they look up on WebMD, guess what it always is? They have cancer, right? So it's usually a frequent reason for them to come in and see you potentially as a healthcare provider. But some things they might look out for, and again, caution is going to be the mnemonic here, but things like changes in bowel or bladder habits could be indicative of a type of cancer, sores that don't heal, bleeding that's unusual or discharges, say lumps or thickening of tissue in certain areas, if they're having a problem swallowing, especially here in Florida, having a lot of skin cancer being a big problem. They're noticing sort of changes in warts or moles, and then any kind of hoarseness, nagging cough could be indicative of different types of cancer, right? So obviously, things like the lumps in the breast tissue would be indicative of breast cancer, right? But again, these are just kind of early things that may prompt a patient to come get checked out. And so how we classify the tumor is first off by the cancerous cell. That tells us the type of tumor it is. And then we'll find out based off of that, do they tend to proliferate rapidly? Do they increase in number, or is it more of a slow-growing tumor? Sometimes that can give us an idea of how aggressive it is. And then whether or not it's going to be resulting in significant morbidity or mortality. So for instance, if you have severe leukemia, you're going to be potentially immunocompromised because your white cells are very immature and they don't function very well. That'd be morbidity, or it could lead all to mortality and death. The original site of the tumors, or where it came from initially. So say, for instance, it came from the breast tissue, right? And then if it spreads or metastasizes, maybe you'll find those breast cells, mutant breast cells, somewhere else within the body at a new metastases, right? Every new site, other than that primary, is going to be considered a secondary site. And then we'll also talk about, based off the type of cancer that it is, what kind of drug treatment we're going to need for this. And certainly the three big modalities you're going to see here are going to be surgery to remove sort of well-developed solid tumors, radiation, which is going to be able to provide more diffuse potentially, or killing of cancerous cells, and then drug treatment, which is what we're going to be focusing on. It's very good at getting more diffuse, sort of spread out sort of cancers. And so you're going to find that a lot of our antineoplastic agents may not directly kill cancerous cells, but they may prevent them from growing. And you kind of think about how antibiotics worked for bacterial cells. They're very specific for those cells. Chemotherapy is basically going to be specific for these cancer cells in some cases. However, the specificity is not great, and so you're going to also find it causes a lot of side effects because it affects our normal healthy cells as well. But typically what we do, say we have a malignant tumor here, we give a course of chemotherapy that helps to shrink down the tumor. And then you give second rounds, right? So you basically give the body time to recover, and then you give second rounds of chemotherapy to knock it down even further. And then eventually our own host immune system will be able to come along and, say, for instance, macrophages can come along and phagocytize these remaining cancer cells and hopefully get rid of them. Now, I won't cover every different type of chemotherapeutic agent we have available. I'm going to talk about them in the broad strokes in terms of where they're working at. Most of the time, you're going to find a lot of our agents are working to interfere cell replication. You'll find that some of them will work to, say, block DNA synthesis. That way it cannot produce new DNA to replicate. We'll find there's other mechanisms as well, but this is a really good chart to kind of show you where the different agents are working here. And again, this kind of goes back to your basic biology 1 sort of talk of the cell cycle, where you talk about your prophase, metaphase, anaphase, typical mitosis kind of stuff. You can see where the drugs are actually working at. So for instance, here we'll have something like a plant alkaloid like vincristine. These are antimitotic agents that actually prevent the spindle formation from occurring here, and that way in the metaphase it prevents you from actually pulling those chromosomes apart, and thus if that doesn't happen, you can't form 2 new cells here. And so in that point, that leads to arresting of the cell replication and eventual cell death occurs, right? So there's a lot of different ways that this can work, and we'll kind of talk about them in the broad strokes here coming up. Now, keep in mind that antineoplastics are going to have very toxic effects on normal cells because they're not really specific for attacking just cancer cells. That's starting to change a little bit, as we'll talk about a little bit later on. But the primary things you're going to run into are going to be things like bone marrow suppression, meaning you're going to suppress your white cells, meaning you can get infections, meaning you're not producing things like platelets, so you can get bleeding. You can get stomatitis, meaning sores in the mouth that can make it very difficult for them to want to consume liquids or food potentially, right? And then you see a lot of nausea, vomiting, and diarrhea. So a lot of these drugs tend to directly trigger vomiting within the brain. There's something called the chemoreceptor trigger zone that causes that. But also think about the fact that because cancer cells are rapidly dividing, they're very susceptible to the antineoplastic agents here. Well, all of your normal cells, which are rapidly dividing, get hit as well. So that's why the bone marrow is going to be suppressed. That's why you're getting stomatitis. A lot of your GI cells that are constantly replicating get affected here, and also your hair cells, which is why you end up seeing hair loss as a common side effect of many types of chemotherapy. Not only that, but all these are going to cause fetal malformation, so these are going to be all contraindicated in cases of pregnancy. And again, you may find that certain drugs are associated with very specific side effects. So for instance, the drug doxorubicin or daunorubicin can cause CHF because they actually cause a cardiomyopathy because they directly attack the cardiac cells, right? Some of them can cause things like hemorrhagic cystitis because they have metabolites that directly affect the bladder. There's a lot of different problems here that can develop, and as you work with these patients, as you work with these medications, you get a really good feel for that sort of thing. Again, just another way to give you some examples of different issues here. So for instance, the plant alkaloids we mentioned a few slides ago, things like vincristine and vinblastine, they cause what they call a stocking glove neuropathy, where basically the distal nerves in the hands and in the feet get affected. So they can feel burning, they can feel pain, they can feel tingling, and that stocking glove sort of distribution. So that's just one example, but certainly a lot of other problems can develop from the use of antineoplastics. And so what are some other things to note in terms of patient education, how to help them be compliant? Well, anxiety is going to be an expected response, right? So patients oftentimes not just need help from the people that diagnose them and treat them, but also things like mental health providers that can help to counsel them through the process. Patients, are frequently racked with anxiety, with fear, and this is where these patients need a lot of emotional support. Good nutrition is really essential, and this may be really difficult because patients oftentimes do not want to eat when they are receiving chemotherapy. They feel so miserable, they're nauseous, they just don't want to eat, and so their weight tends to go down pretty drastically in some cases. This is frequently why patients will often use things like medical marijuana as an appetite stimulant to help them want to eat, so they'll actually put weight back on, right? And again, lesions in the mouth or bleeding of the gums, common, and another reason why they may not want to be eating so much, right? But other things we're going to find here is that they need to be aware of things like fever is very common, sore throat, infection, blood dyscrasias mean they're going to have issues of producing platelets and white cells and red cells and all these different things here. They need to be educated on these and what to look for. So if a patient who has active chemotherapy and say, for instance, they have a low white count and they're immunosuppressed because they've received like chemotherapy and they develop fever, they need to know that's a reason to come right into the ER because that could be the only sign that they have an infection and they need to get broad spectrum antibiotic therapy on right away, right? They call that febrile neutropenia. That can be potentially deadly if not caught early. There's a lot of things that go into it, and patients will be educated on these different points and hopefully help them to stay compliant with their therapy. Now, things to consider when you are dealing with chemotherapy is that cancer chemotherapy, using the actual drugs themselves, tend to be more effective against very small tumors and things that have good efficient blood supplies, and they have a really high percentage of fast-growing cells. This means you can get the drug directly to the tissue, and because it's rapidly dividing, most of your drugs can work very effectively there to prevent them from replicating. Typically, what you're going to find is that most patients will either end up getting a round of surgery or, say, radiation prior to getting chemotherapy. Imagine if you have, say, a large solid tumor, say, in the brain, for instance, and the surgeon goes in and cuts that out. Well, there's no way to know that they got every single cell there of cancer left over, so they will usually do surgery first and then follow up with chemotherapy, make sure they got any other cells that they could have missed during surgery, right? By combining the two together, you get better synergy and you get a better likelihood of success. Now, typically chemotherapy is going to be directed towards controlling the abnormal growth, so they may not kill the cells off directly, but may prevent them from replicating. And so you tend to find that we'll give really high doses at first to try to get as many cancerous cells as we can, but keep in mind that's going to get a lot of healthy cells as well. So we'll give them big doses of chemotherapy, and then we back off for a while. We give their healthy cells time to recover, and then you hit them again with another course. And so they typically go through these cycles of chemotherapy to try to get them to eventually no cells left, no cancerous cells, so that way they go into remission. And just know that the more elderly patients you have, the more likelihood they're going to develop more cancers. They're also going to have a lot of recurrent illnesses like hypertension, diabetes, different things like that. That's going to complicate their therapy, so you have to be aware of that. And then typically children tend to respond a lot better. We get a lot of really good successes dealing with pediatric cancers. And so this is just because they are relatively healthy compared to older adult patients, and so they can handle the chemo a little bit better. Now again, different classes of antineoplastic agents you may run into, things like alkylating agents. These actually will directly alkylate the DNA and will cause mutations to occur, which eventually leads to apoptosis to be triggered off or programmed cell death to occur. We'll have things like antimetabolites that actually interfere with the production of new nucleotides in the cell, which again directly affects the cell's ability to undergo mitosis. I mentioned the mitotic inhibitors that actually prevent the microtubules from forming that pull the paired set of chromosomes apart, which will stop cell reproduction. And then we'll even have hormone therapy that works selectively on target lesions. So, for instance, if you have hormone-sensitive breast cancer, meaning estrogen stimulates that tumor to grow, we can give things that block the activity of estrogen in the breast tissue to prevent that tumor from growing, right? So a lot of different ways we can go about it, and frequently use one or more of these to get better synergy. Other things like anti-tumor antibiotics will inhibit DNA and RNA synthesis. Sometimes we'll give immunosuppressants that will basically allow our antineoplastic drugs to work a little bit better and render some of the cancer cells potentially non-malignant. And then nowadays you're starting to see newer drugs that are going to be working on very specific body organs or specific cell tissue. So for instance, you can have, say, a patient with a type of leukemia. If they have one particular mutation that they express a certain type of receptor, there's a drug that works extremely well on that, but only on that particular mutation of that particular cancer. So they can get very specific, and we're seeing more of that, which is good because it actually helps to limit a lot of the toxicity you see with traditional chemotherapy. So in terms of handling and administering, so if you're going to be a healthcare provider that's going to be working with these medications here, it's really important to understand that they can be mutagenic, they're teratogenic, and they're carcinogenic. So it's very, very important that you treat these with a healthy dose of respect, because if you get exposed to it, it can potentially cause cancer in you, right? So because of that, you want to avoid any contact with the skins, the eyes, or mucous membranes. You have to make sure to follow any kind of OSHA or manufacturer guidelines, and you want to make sure that whoever's administering it has been cleared to do so. So typically, nurses have specific training that they do to get certified. So that way you have certain chemo nurses that will only administer chemotherapy, whereas your other rank and file nurses are not able to, because they don't have that extra training. And even in the pharmacy side of things, we have to make sure we use hoods, biological cabinets basically, where we produce this stuff to make sure that none of it can be exposed to us, right? That way any liquids or anything gets sucked up into the ventilation system, none of it can be exposed to the people working with it. And then it's really important that when you're administering chemo to use personal protective equipment, or PPE. So that frequently means you'll have a mask on with a splash guard over your eyes, you'll have a gown on, you'll have gloves on, and that way prevents it from potentially being exposed to the people who are actually working with it. And then in terms of dosing, just really quickly, this gets really important because if you screw this up, you can give the wrong dose to the patient, which can either lead to their cancer resuming its growth, which can lead to relapse, or potentially you give way too much, and that can lead to severe toxicity in the patient. And so it's important to know that sometimes we'll use what they call milligram per kilogram dosing, where they may get 5 milligrams per kilogram of a dose for a drug. A lot of times they'll also use what they call BSA dosing, which is body surface area, which is in milligrams per meter square. So you want to make sure whenever you're looking at dosing for chemotherapy to make sure you keep these two straight and not to mix them up, because you can get wildly different doses and that can be a big problem. For BSA, and I think we've covered this before, basically you just plot the patient's height and their weight, and then eventually you cross that over, and wherever you get the eventual BSA, that's how you dose it. Okay. So that's it for this section. If you have any questions, let me know, and I'll talk to you soon. Thanks a lot. Bye.